Thanks, Andrew. What a lovely introduction. Good afternoon, everybody. I'd like to acknowledge the traditional owners of the land, of this wonderful land we live in, and pay my respects to elders both past and present, particularly if there's any elders in the room this afternoon. Also, I'd like to acknowledge the Australian Private Hospitals Association, both Michael and Lisa, for the invitation. And it's nice to see you all here, taking a couple of days out of a busy week, reflecting on the good work that you do. And Cathy and I will talk sort of in tandem this afternoon. It is after lunch, so we've got a few videos, and now that I saw a popcorn machine, we can break out the popcorn and watch a few of these videos as well. I'm not sure if they brought the popcorn machine because they knew we were going to speak this afternoon or not, but it's great to see it. I'm just thinking, looking around at the room, imagine what it would be like if the room was full of your patients. What would the feel of the room be like? What would they say about you? I'd imagine and I'd guess that most of them, the things they'd say would be quite positive. One or two might have some complaints, and there'd be a few who'd have suggestions about how you could move from very good to excellent and be the best possible service you could be. So I'm guessing that's what would happen if we had a room full of patients. And why would they give you some feedback? Why would they bother? Why would they care? I think there are two reasons. Everyone has a story to tell about their healthcare, whether it's yourselves, your loved ones, your family, or your friends. We've all got a story to tell. It's what we do as human beings. We tell stories. And that's what our patients do when they talk to each other. They tell their stories. But there's another reason why I think they'd like to tell stories, and that's because we work in an industry that really is in a unique space. Although we have similarities with, and we heard this morning, with hotels and restaurants, we're not like hotels or restaurants. We're something different. And the reason we're something different is because in our industry, we work on the edge of the human predicament. We work with people confronted with suffering and asking questions about the meaning of life. Why am I sick? Will things get better? How will my life be different now after this operation? How will my life be different now that I'm not going to get better? So we work on the edge of the human predicament. We deal with suffering in many forms: physical, emotional, social, spiritual. Suffering is part of who we are as human beings. It's part of the human condition. We are shaped by it, both personally and professionally. But I'm not a romanticist. My wife will tell you that. Suffering is unkind, unfair, unjust, and often untimely. But suffering is the space that we work within. That's why we are different from hotels and restaurants. If we let it, suffering helps us get in touch with our own humanity, who we are as carers. It taps in to our core values. So capturing the story is important. I don't know about you, but I get a kick out of helping other people. And I'm sure most of you in the room do as well. I get a kick out of it because it helps me become other-focused, not self-centred. Helping others helps us become other-focused. And hearing the stories of our patients, of the carers, of families, reminds us of what we do well on the edge of that human predicament. It reminds us of course, where we might need to improve and become even better, to become the best that we can become. So what I'd like to do now is just share with you a short video. It's a video of Dr. Kieran Sweeney, a GP, a mate of mine, a colleague, a golf partner, a doctor and a medical philosopher. Kieran's now gone to God. He passed away a few years ago. He passed away from asbestosis disease, mesothelioma. And so I'd just like to, he shared this video with the King's Fund in England about 2 months before he passed away.
The diagnosis was established very quickly after I'd had an X-ray, which had shown pleural effusion in my right lung. I'd had some symptoms, a cough, which I thought was a viral infection for about 8 weeks, but because it persisted, I asked my GP for an X-ray. And at that point, he set up very quickly an appointment with a respiratory physician, who in turn set up an appointment with a cardiothoracic surgeon for a biopsy. And really the whole procedure from being referred to having the biopsy took place over about a week. And I think actually operationally couldn't have happened any more quickly. So technically things went very swiftly and very positively. But it was after I'd had the biopsy, which was, again, the anaesthetist was round and asked me was I okay, and the third surgeon came round and asked me was I okay after the biopsy. But what was interesting was that they all looked very, very despondent about their findings. Their findings were on a video-assisted thoracoscopy, so everyone could see my chest, which looked terrible, looking at the reports. And increasingly, I became aware of their despondency. So I got more frightened, really, as that period went on. And I remember the SHO coming into the room. He'd been an undergraduate student with me for a year or two. I knew him very well. I could tell that he was very, very upset and wanted to talk to me about it. But I think he felt that he didn't have the authority to do that. So I left hospital the next day, still without any clear understanding of what was happening to me, and came home to the kitchen in my house, where I opened the discharge summary, because I have access to my own records, obviously, and the discharge summary included the phrase, likely malignant mesothelioma, patient aware of diagnosis. So that's how I learned that I had a mesothelioma, reading it in the kitchen table. I think it's important to say at this stage that although that wasn't the right way to learn about it, I think everyone was trying to do the right thing. The first I learned directly that I might have a mesothelioma was from the specialist cancer nurse who came in to show my wife how to drain the pleural catheter, which was in my right chest. And he, again acting very conscientiously, said to me and my wife, if I wanted any information about mesothelioma, he'd lots of it available. There was a point where everyone in the team, including my wife, knew that I had a mesothelioma, and I didn't. And that can't be right. I think there may have been something in the fact that being a doctor, I'm being roughly the same age as these guys. I'm in my late 50s. Most of the consultants were in their late 50s or 50s, you know. And our kids would be the same age. This is completely cut and just diagnosis. So you can see them thinking, God, this guy's out with. And they just weren't brave enough. They weren't brave enough to say, this is really bad news for you. Maybe that they hid behind the science of their biopsy and pathology to avoid confronting the metaphysics of my predicament. I am a man devoid of hope. And I just sensed that they hesitated at that point. And my own view is, sounds quite hard, is I just don't think that's good enough. Medicine is not solely a technical activity and pursuit. Medicine is about understanding and being with people at the edge of the human predicament. Caring for somebody is a transactional activity where they do things to me. Everything that I've had done to me in our local hospital has been excellent. There has been a single mistake. I'm seen it on time. For things transactionally, I think the place is outstanding. It's the relational care where I felt that the experience has been less than satisfactory. And it's been a mixture of some really shockingly bad interactions and some shockingly good interactions, some surprisingly good interactions. But again, I want to stress that when I perceive people to be interacting poorly with me, I still, and I mean this, I still think they're trying to do their best. I still think they don't think that they're actually upsetting me in a particular way, but they are. And my insight into the experience is it doesn't take much to change from upsetting or insensitive communication to communication that puts someone much more at their ease.
Okay, let's continue. That was, hopefully you understood the accent in that video too, and sorry we couldn't put it on the very large screen. I'm not going to ask you, you're probably very relieved, I'm not going to ask you what your learnings were from that, I'm just going to tell you mine. So I will just move on. Here we go. So the three things that I took away from that video when I first watched it is just the very common sense issue that the patient should be the one that knows the most about their condition. They really should. They should know the most about their condition the whole way along. And one thing that I remembered when I was watching that was the last time I was in hospital when, thank goodness, the hospital I was in did bedside handover, which was wonderful. And the reason it was wonderful was that's the only place I ever found out what was going on with my own care. And I found out something new every time the nurses came around and did bedside handover. But the patient should be the one that knows the most about their own condition. The second point is what he made very well, that the care was exemplary, there were no mistakes, there was nothing that went wrong and everything was done beautifully. But even then, lack of empathy will destroy the hospital experience. So it'll just ruin your patient's experience altogether if there's no empathy. And emotional support is the thing that is most lacking in our hospitals, judging by lots of the feedback we're getting from patients in our Hellscope hospitals and in other hospitals as well, that emotional support has gone. We're not providing it anymore in the way that we should be. So they're the three things I got out of it. Have a think about what you get out of it and whether you can take something back. And I'm just going to tell you a little bit now about Hellscope's consumer participation program. And then we're going to go back to Michael to talk a bit more about the patient opinion website and how that fits into Hellscope's consumer participation program. I'm not going to go into every detail of it because we don't have time today, but I'll just talk about two things mainly. The first one is our patient-centred care program, which is pretty much our customer service training and our customer service program. And I'll just briefly mention that. I've done plenty of talks on this in the past. But also how to involve consumer consultants a bit more in your organisation in order to get better patient feedback. So they're the two things I really wanted to touch on as far as what we're doing at Hellscope and then how patient opinion fits in with all of that as well. So just very, very quickly, here are some of the patient-centred care strategies that work best at Hellscope. And we have 45 hospitals, so there are a lot of different variations in our hospitals, and they get to choose from a menu of, if you've read the Plenary model books, you've got about 100 different strategies or more to choose from if you're really wanting to implement patient-centred care. So some of the ones that we have found the most useful, and lots of different ways of doing this, but the education program that we've rolled out is a Hellscope specific education program, and just reminding all of the direct care staff constantly about customer service, in particular patient-centred care customer service. It really should be something that people are getting every year. It isn't something you can just provide on orientation, and it is one of those ones that falls by the wayside because, of course, with the new national standards we have another 20 mandatory training things that we're supposed to do. But patient-centred care education is one of the best factors as far as keeping that empathy and emotional support high amongst direct care staff. Some of the other things we've been using, bedside handover, the difference at Hellscope is that we told our staff it was mandatory, and not everyone is doing that, and that's been very effective. There was no questions, everyone has to do it. We rolled that out in mental health as well, and there were no excuses allowed as people not implementing bedside handover. And once you have a few hospitals doing it, getting some momentum up, it's very, very easy to roll that out in the subsequent hospitals. Difficult in the initial stages in some places, and of course cultural differences are everywhere. But bedside handover is probably the thing that the patients are saying makes the biggest difference to their communication and empathy and emotional support as well. Flowing on from those bedside progress notes is a very easy continuation of that. And at the moment, hourly rounding is the topic that we're looking at the most closely, because we're finding that the hospitals that are scoring best on patient experience are using hourly rounding. So just investigating, again, in the same vein as bedside handover, the patients are really appreciating that extra contact and how to do that. And there's a lot of models for hourly rounding as well. Some of the other things that we've also done that have been particularly helpful, a bedside question sheet for doctors, because in the private sector, of course, we don't have doctors going around every 5 minutes. We don't have the junior doctors at the bedside as often, and so having an alternative for the staff is very important. Some scripted leadership from the general managers and directors of nursing who are perhaps not so up with the research on patient-centred care, making sure they know what to say to their staff to encourage them is very important. So that's part of the strategy. And whiteboards, even though it's an old-fashioned idea, again, the patients really like the whiteboards, and we have a lot of different models for that going at Hellscope. But that's just a brief idea of the package of patient-centred care strategies that are working, and the hospitals that have these working the best are getting the best experience scores. Which ones are the most associated with improvement? As I said, the education and the bedside handover, but also the CEO leadership. And this is where, just to be a little cynical for a moment, you can fake this, of course, and that's where if you have managers talking about this all the time, it'll make a much bigger impact on the staff than just someone coming around and saying you must attend this education program. The general manager, the CEO of the hospital, has to talk about this all the time, or it won't happen. And you can't expect the CEO to come straight out of a 3-hour finance meeting with the board and suddenly talk patient-centred care. You need to provide, you need to actually have scripts there available to say this is exactly what you need to say here to inspire the staff. You've got to give people some tools to do this, and that's what I meant by the scripted leadership. Of course, there's plenty of people out there who can do this without a script, but it is important to make sure that even the directors of the nurse unit managers on particular wards won't necessarily know what to say to inspire their staff to do this. And you need to give plenty of tools out there, need to give them those tools. Now, just to move on a little bit, to talk about the national standards and how to meet standard 2, the consumer standard, which is one of those standards that is the most subject to not met criteria at accreditation. We have an entire wonderful standard related to consumer participation. There are not many mandatory or core items in that standard just yet, and there will be more as the new national standards are rolled out and revised. One of the main ways that in the private sector that we can do this, and I don't see a lot of differences between the public and the private sector here, but making sure that if you don't have an active patient population that you can get feedback from, you're not perhaps having repeat patients as much in a highly surgical related hospital or health service, using your consumer consultants to obtain that feedback is probably one of the key go-to strategies here. So we find that using consumer consultants means that you've got a regular body of consumers that you can go to get your information. You can use these consumers to educate staff. We actually use our consumer consultants to do some auditing and do some patient surveying, getting feedback. And if you're wanting your consumers to do some education for your staff, which is very, very powerful. I mean, imagine if you had Kieran actually educating your staff on empathy and patient-centred care. It is far more effective to have a consumer talking to your staff, but you need to find a consumer that knows how to talk. And so there are places you can go for that, as we suggested, Toastmasters or similar. And again, if your consumer doesn't know what to say, you just script it and practice it. And so with our surveys that we get the consumers to do, and I'll put a slide up in a moment, scripting really works. And I think we should be using that a lot more than expecting people just to know what to say. Just some other ideas. The standard really provides you with a list of things that you need to do, and we're very, very quick to say this is all very hard, and I don't actually think it's that hard. It really isn't that hard to send your consumers some brochures to review, to get them involved in strategic planning, to think, gee, we're building a new hospital, we better ask the patients what they want. Isn't that hard, even in the private sector? And there are lots of different ways you can do it that are listed on the slide. Involving consumers directly is difficult, I think, with a big patient group, but with a consumer consultant on board, then it becomes much easier. With our consumer consultants, we don't necessarily have them even coming into the hospital. We have a lot of consumer consultants that only work via phone or teleconferencing, by text, that look at the website. We have Skype or video conferencing for those. We may get them together once a year and we run orientation sessions and so on. But it isn't mandatory that they come in all the time into the hospital. And there are lots of ways of involving consumer consultants in particular in this way. We have action plans for our consumer groups, and there are plenty of resources, as we mentioned before, online. So this is, I guess, one of the main things that we're trying to do. I think we should be paying the consumers just an hourly rate. That might be a token hourly rate. Making sure you have a consumer participation committee. Now, the reason for this is we often get consumers involved in our hospitals and we don't document it. And that is one of the main reasons that you'll find you're failing something in that standard 2, because the consumers were involved, but it happened on the ward and the staff member was there, but no one documented it. You really need some kind of committee, even if it is just a consumer and the quality manager and the director of nursing, 3 people or 4 people, so that you actually officially document all of the involvement the consumer has had, because the consumers will have a lot of involvement that perhaps isn't there. And when it comes to consumer consultants doing audits and surveys, again, you find you get a lot more frank comments from your patients if the consumer consultants are involved in seeking feedback. Of course, they need training in how to do that, and you might find they're already better than your staff at doing that anyway. But they do need training, and there are lots of good websites available for that training as well. For example, an ID band audit is not difficult to get a consumer to do. The consumer doesn't even need to really, touch the patient or anything. It's just having a look at the ID band, etc. So we have got our consumer consultants to do quite useful audits and surveys, and the consumer consultants want to be useful. They don't just want to be given something silly to do. And just on the last slide, I'm just going to mention on this is just very practically, we recommend our hospitals do a 3-question survey. Patients are sick of filling in written surveys. Now, they do like going online, which is what we're going to talk about in a minute. But in getting an old-fashioned written survey, it isn't so popular anymore. And if they do get a written survey, they want it to be short. But interview surveys are a lot more effective. You get a lot more rich data. And so we recommend just a 3-question survey. So whatever your topic is, in this case it was a day procedure recovery unit wanting some feedback, we don't let them ask 10 or 20 questions. We just say, okay, go around to everyone in recovery, we script this out. What's good about recovery, what's not so good? So you get a couple of items of qualitative information, some positives, which is very important to give back to the staff, perhaps some negatives in the second question, what's not so good. And then it's always good to have a quantitative question, because you might want to repeat this survey later and compare. So you do need, perhaps, give me a score out of 10 for recovery. And so you can get a little bit of quantitative information, some good qualitative, some bad qualitative, and that's enough. We just don't want to go any further than those 3 questions. So we recommend that for any particular specific topic, and our consumer consultants progressively are being trained to do this, and some are better than others, and not every hospital is doing this yet. So that's, I guess, the last slide that I just wanted to finish on as far as the Hellscope consumer program goes. Well, I'm just going to get you to do a little activity again now, because we are in the post-lunch session. And what I want you to do is, if you haven't done this before, get your phones out. Everyone got their smartphone or your iPad. If you don't worry about it. You can just look at the next person next to you. And we are going to do an activity where you're going to Google your hospital. So and you may have already done this many times, and you may have someone in your hospital doing it, but it's definitely something that's worthwhile doing if you haven't before. So what we're going to do is type in to Safari or Google or whatever your search engine is, type in the name of your hospital and type in the word MAPS. So we're going to a very specific website here. So just type in Nepean Private MAPS and hit enter. And what you'll probably end up with, I don't have a picture of it here, is the standard Google landing page for MAPS, and quite often there are reviews there. So patients will have left reviews for your hospital in that particular spot. Again, I'm not necessarily going to ask you what you find in there, but if you can click on those reviews, it might be 3 reviews, there might be 10 reviews, there could be 0 reviews there, but that's a good place to start. I'll just read you some of the reviews that I found, and I just went through this about half an hour ago. So this isn't my hospital, this is a hospital I've been admitted to though. We get, it's a hospital but nice and pleasant, and another person has put, the nursing staff just milled around and stared, which is a nice one. Some more reviews. Unfortunately, this is one of my hospitals, I'll just read it out. Prince of Wales parking lot sucks and is expensive. They should be in jail for what they charge, and the service they provide is shocking. So a car parking comment is hardly surprising. And then you get something else. Whilst being a young Australian male, I have seen several public hospitals in different states. This is the best one by far. I'm not quite sure what that means, why someone would be in hospital in several different states. But this is my favourite one. This pertains to the emergency department. The front desk staff try really hard but are very defensive. I assume from lots of abuse, which this hospital deserves. So there's quite often some very helpful feedback, but the point is, I guess, that people can put feedback anywhere on the web, and I know you've had talks about this in the past. You do need to be keeping an eye on that in some ways, and they are hard to find, and they're hard to respond to as well. So if you don't know where they are, that can be one of the problems as well. Okay, so that was just a little activity now, you can get distracted. But just to talk a little bit about patient opinion, we are using patient opinion in 2 of our hospitals, and Michael will talk a little bit more about how it all works and what happens. But it's part of our consumer participation strategy. We also have a complaints process and a compliments process at all of our hospitals. We use Riskman for recording those, and we have a complaints officer at every hospital. But patient opinion does it in a slightly different way, and it's another way of collecting the feedback and encouraging. You can encourage your staff to your patients to post feedback, and it's not just on your own website, it's on a more independent website. So sometimes patients are far more keen to do that, and there's a whole lot of resources available that Michael will talk about. But we're trialling this at Geelong Private Hospital in Victoria and Sunnybank Private Hospital up in Queensland, in Brisbane. And we'll talk a little bit more about and maybe show you about how to do that in a moment. So it's over to Michael.
Thanks, Cathy. I know you said staff can write on there, and you sort of went, all patients. But actually, staff can write on patient opinion. About 2% of our stories come from staff who have suggestions about how their own hospital could improve its quality. So, as Cathy said, just wanted to give you a bit of an idea about what's different about the site, and it might be, or may not be, a piece of technology that you might want to make use of. So it is a website where the public can publish their experiences, and it also allows health service staff to interact with these patients to help improve care. As Cathy said, we're not for profit, and we're not about just having a chat on the web. It's really about helping improve health services through that open and transparent dialogue between the patient and the users of the service and the health service providers. I'll just show you a quick animation. It goes for about a minute, and it just gives you a bit of a drawing snapshot about what is this patient opinion, what's it about.
Meet Hillary.
My mum was on a hospital ward and there was no phone, so we couldn't speak. So I went on the patient opinion website and I told my story.
Meet Brian.
When I was diagnosed with bowel cancer, it was the nurses that helped me to accept what I was being told. I wanted to let them know what they did for me and to keep doing it for the next patient, so I told my story on the patient opinion website.
Your story comes to us at Patient Opinion. We send your story anonymously to just the right staff so they can hear what you think. they can share it with other staff so that they keep doing the good things and change the things that need changing. Hilary told us,
The next day, the hospital put a phone for patients on my mum's ward. I think my story is rather boring. It's about phones, but I think it made a difference, not just for my mother, but for the other visitors and patients in that ward.
we hear hundreds of stories from across the country and, together, we're all making healthcare better. What's your story? Tell us about your experience of using health services at www.patientopinion.org.au or give us a call on 1300 662 996.
Thanks for that, Cathy. So patient opinion is not just Australia. It's actually in Scotland, England, Ireland. It's now looks like it's going to be moving into Canada, Italy and New Zealand possibly. So it's a social movement really that's happening. And I'll just tell you a little bit more about it because you're going to hear more about it. People have always talked about you. We just saw, I wasn't aware of maps either and going in, but people are talking about you. They're shouting about their experience on the web. In the past, they used to talk about it at the family barbecue or the family gathering or down at the local sports club about you. But now they've got more of a voice now in terms of writing it on the web. Question is, who's listening? And that's why patient opinion was developed, is to try and bring those conversations into a safe place that can be helpful for organisations. You know that social media, and this really builds on Lisa Ramshaw's talk last year about social media. It's a process of people using online tools and platforms to share content and information through conversation and communication. And there's lots of types, and I know most of you, if not all of you in the room, will be on one of these forms of social media. You may not have known that social media actually bypassed email service usage in October 2007. So there's the internet traffic is much higher on social media now. It has been for the last 7 years, more so than email. There are folk now that do not use email. They'll just have an email message. Here's my Twitter handle. If you've got something to say it here. And they'll just say it on Twitter because they realise they're very busy executives, and if you can't say it 140 characters, don't say it at all. So people are now moving away from email to Twitter. In terms of how this fits in, I mean, here's a quick 2x2. Facebook, Twitter, all those sorts of social media platforms are what we call generic platforms. There are custom-made platforms like Patients Like Me, Mumsnet, NetMums, or disease-specific type group platforms. They are tailor-made for driving various social conversations. We tend to sit more about citizen feedback to help services improve. So you won't find people generally having a chit-chat on patient opinion or a rant and a rave. It really is about driving conversations to help improve services. The generic platforms are somewhat reactive, so they just go up immediately. The other ones in terms of social conversations tend to be supportive and consultative and campaigning. And really what patient opinion solely is about is driving participation and driving change. And you might be surprised to know that it was developed by doctors, a GP and a hospital physician, because they were rather irate about the doctor rating websites that were appearing back in the 2006-07, and they felt that they were destructive rather than constructive. In terms of whose terms do you engage with, Cathy gave an outline of Hellscope's consumer participation strategies, and one of them is patient opinion, but there's several others. So this is really a string in your bow, I guess. But on whose terms do we engage with our customers, our consumers, our patients? Generally, if you look at this continuum, easy for the services to use and hard for services to use, and then the public's the horizontal line, generally things like the family and friends test, how likely are you to recommend the service to your family and friends, patient surveys, focus groups, we would generally say they're relatively easy for an organisation to use. What's a little bit more difficult, but still relatively easy to use, but hard for the public to engage in, are formal complaints. I don't know if you ever lodged a formal complaint. I haven't, but I've spoken to people that have, and it's quite a difficult process, even with Health Ombudsman and online complaint systems. It's an ordeal. So these were what we call relatively easy ways, and it's really the way we do tend to engage with our users of our service. I guess what's hard for everybody, public and ourselves, is litigation. No one wants to go down that route. What's becoming easier for the public to engage in, we just saw Cathy who gave that example, are the blogging sites. So people can go on the web and just say what they want. And that's very easy for them to do. As long as they've got internet, they can do that. But the problem with that is that you, as services, find it difficult to engage in. So whilst people are shouting on the web, it's probably not getting to the right ears to the people that can make a difference. So that's why patient opinion and care opinion were developed, to make it easy for the public to engage in. It's independent, it's accessible, it's anonymous, it's safe, it's constructive. But it also is easy for staff to engage in, because we're going to give a demonstration later of just how easy that is. And it starts to change mindsets within organisations when your staff are receiving stories about their services. Now, you might think, God, I don't want my staff getting negative stories. Half of the stories on patient opinion are positive. You saw the quick animation. We need to develop a culture where our staff beg for people to tell their story about what they've done well and what they might do differently, if at all. We need to develop a culture where we really portray, we love your feedback. Your feedback helps drive what we do. If we go back to what I started at the beginning, we're touching on the humanity of care. So we need to know what we're doing well. We need to know how this impacts on people. And I often speak to health services, and there's perception that it's really only going to be negative. Well, surprise, surprise, it won't be. If you have a culture that welcomes that feedback, you'll find that people really do want to thank you and tell you what you do well. The outputs on the left-hand side are really opaque to the public. You might publish them on your website, but generally they're top managerial sort of level outputs. They are opaque to the public, but we're moving towards transparent. These outputs on the right are transparent to the public. Everybody can see them. So very quickly, and we'll go, the patient tells their story. Once they tell their story and submit, it doesn't go live, but they get an email alert saying, your story is important to us, thank you for your story. If it meets moderation policy, we'll publish it. So they're immediately being heard as soon as they push that submit button once they tell their story. It comes to our team, it's moderated to take out any identifiers, not only of the patient, but of the staff. So if they mention, the staff member, we take out all names. And we also do a bit of background work to make sure that, if there was only one plastic surgeon in Thargomindah, and the story mentions plastic surgeon, then we obviously don't mention plastic surgeon, we mention staff member. So we try and de-identify things as much as possible so the public don't know who that, because we don't want any, name and shames. Once the story is published, which might be the same day or the next day, depending on how critical the story is, if it's a very high critical story, and about 5% of our stories are what we could call a typical complaint, only 5%. And if it is that story, we get back to the service provider and let them know there's a story about them and do they want to respond. We do that to any service provider. And in the early days, 85% said, who are you, we don't care. 85% now are saying, yes, we'd love to respond. As soon as they respond with a critical story, they both go up at the same time. But if it wasn't a critical story, as soon as the health service provider responds, the story writer teller gets an email alert immediately saying your story has been responded to. And the staff, depending on who's set up to receive email alerts, can be automatically email alerted. And the patient can also comment back on that particular response. What people can't do is log in on the conversation. So it's only a conversation between the storyteller and the health service staff. And there are people who tend to watch the stories, so we have a lot of watchers like the Commission for Safety and Quality, various government departments, health consumer organisations, patient advocacy groups. So they're watchers on the site. So they might say, like, for example, the Victorian Mental Health Complaints Commission, they're a watcher. They ask for any stories about mental health stories. So the person telling the story will know that people are watching the story. But it is all about service improvement. These are the sort of, this is based on 789 stories told, 222 staff listening. So about 59% of our stories are positive on the site, and about 3% in this case are what you call complaint level, and then the minimally, mildly and moderately critical are really just some concerns and feedback, and they're often a mixture of positive and negative within that as well. So, you know, the doctor is really lovely, but I wish the nurse smiled occasionally or something. So it'd be a mixture, and that by me it might be a level 1 or level 2 sort of criticality story. The public don't see this, only the service providers see this. So all the public see are the stories, which are de-identified. So what I'd like to do now, so really I hope you're getting a sense of, this is about getting stories in real time to staff to help them reflect on what they do, and hopefully most of it's good. And if it's not that good, at least they're starting to get into the patient's shoes, seeing through the eyes of those that use your service. So we're just going to take a popcorn break and play you a quick video called Be Brave. Brave. And then in the context of that, it's being brave about responding to the stories that you receive on Patient Opinion. And let me just quickly show you what that's about. We did in England, it's been going now for 10 years, and it's a leading platform right across. They've got over 100,000 stories, been viewed 70 million times. So people pretty much write their stories when they go into a service in England or Scotland now on Patient Opinion. And as I said, 50% are still positive. But we did a survey just about posting a critical story on Patient Opinion. Did sharing your story on Patient Opinion make it more or less likely that you made a formal complaint? And without a prompt, a follow-up, 67% of people got back to us, which is a great response rate. Half of them said it didn't affect them either way, and when we looked at those half, they tend to be more sort of hotel aspects of care, you know, the bread rolls that Michael talked about before this morning. So, you know, that it didn't affect them either way. But the other half said they did change their likelihood of complaining. And 25% said they would less likely lodge a formal complaint now because there was, and when we looked at those folk, it was because there was a very good response from the health service to their story. But what was surprising was that 25% said they were more likely to lodge a formal complaint. And when we looked at their stories and their responses, there were very poor critical responses to their story. So that, you know, I think the lesson here is it's the quality of, it's not the content of the story that really matters, you know, being public and transparent. It's the quality of your response that matters. And when we tweet our stories, we tend to, what we do is we tweet the response, which sits underneath the story. So people see the response first, and then they can scroll up and see the story. These are what we call not great responses. They're transactional responses. They're real. They're live on our site, but I've just de-identified them. Thank you for your feedback. We take all feedback very seriously, and we would like the opportunity to discuss aspects of your patient care with you. Please contact our patient liaison manager with an email address. And that was it. Now, that might seem okay to you, and it may not either. So this is transactional. If you saw the story, I think you'd be horrified. The story was quite emotional, quite an impactful story, which probably needed something a little bit more, sorry you've had that experience, some empathy there. Another one we had, and we get lots of these, is for any complaints, this was another big story. For any complaints, it wasn't a complaint either, it was a mixture, regarding this service, please contact Patient Representative Office, PO Box. Now these are the sorts of responses that would tend to inflame people writing on the site. In fact, 0 of 14 people think this response is helpful. So this is where the public can go on and share their views about how helpful that response was. And the patient got back. Remember I said the patient can comment back. And in England, some of the back and forth, and they're beautiful. I mean, one led to a clinical improvement, cost-effective solution after about 5 dialogues back and forth. It is wonderful to read. We haven't got time to look at it, but they have several examples of that. In Australia, we're still crawling, as in learning to walk with this. But the patient got back and said, a really helpful compassion, this is the patient teaching the hospital how to respond, a really helpful compassionate response might have been, we're sorry you had that experience while your husband was dying. Compassion is really important to us in the work we do, and we want to give the best service and care every time. If you want to talk to us a little bit more about your experience, we'd value your feedback. Thank you for taking the time to help us improve. What a pity you thought of my feedback as a complaint and gave me another job to do so that you could hear me. Very powerful, very powerful. These are the sorts of good responses we're getting from hospital services. I mentioned this is Linda Hardy, this is Westmorton Hospital and Health Service. So Linda's responded, dear unhappy and frustrated patients, because everything's anonymous. So they give their own names. I won't tell you some of the funny ones. You go on the site and have a look at them. They give themselves an alias name. But, this is Linda responding. We're really sorry to hear that you have been struggling with, constant pain, etc. So, it's an empathy response. It's got a contact there. It's more interactional than transactional. And I know this can be difficult for organisations that are used to that sort of bureaucratic type legal response. We don't have to go there with this. This is a public online platform. This is where things are moving towards. This is a Scottish one. We get hundreds and literally thousands of these. But this is the nurse director, Fiona. She puts her name, she puts her role, and she puts the hospital. And 5 over now, and other people think this response was helpful. And I thought it was a pretty good response, actually. They call themselves Hope Dashed. So, And here's the chief exec of Heart of England Foundation Trust. Andrew's just moved on. Mark. But occasionally the chief exec will get on. They get about 10 to 12 stories a week, so about 600 stories a year. And occasionally the chief exec will come on and write a response, particularly because on average in England, 2,500 people are reading every story posted on Patient Opinion. This story got 8,000 reads. And he knows that. So he goes on and just thinks he's trying to shape... You know how we talked before about how do we educate the public? This is one way about educating the public. So in the empathic response, it's also educating them about the issues that they face. And what subscribing trusts do as well is write a blog. So every time they respond to a story, automatically their blog sits underneath their response. So it might be, for example, Healthscope writing about their values and mission. So every time they've responded to a story, the Healthscope blog sits underneath the response. And there's 10 members of watching this, 7 at Heart of England. When I went onto Nottingham's site, some of the stories, 230 staff have read this story. They are really racing ahead, Nottingham Healthcare Trust. They just won the award for Best Patient-Centred Trust in England. in terms of public online engagement, and their website won an award, and I'll show you that briefly. But and obviously there's some watches, health watches, like the consumer bodies here, and the Solihull Clinical Commissioning Group is another. This is very local, Melbourne. This is, they've just signed up as Eastern Health, so this is Alan Lilly, the Chief Exec. Alan thought, I'm going to put my photo up and have a response as well, so he's in the public health system. They won the Victorian Premier's Health Service Award 2 years running, this year and last year and the year before. And I'm not going to let you down here, Cathy, either, but Hellscope are responding fantastically as well. And we often, we didn't have to do much with Healthscope because they're very much on the ball, but usually some organisations say, well, you know, we'll get back to them. When they respond, it doesn't go live either. It's the same as the storytellers. It comes to us. We normally get back to the server and say, do you really want to respond that way? And the ones I showed you before, they said, yes, please leave it. That's how we want it. But we do give them examples of how other people respond, just to sort of help them. I notice here, it says one or two other people think so, that it was helpful. Molly Pop was the person who wrote the story. As long as Molly Pop's happy, that's pretty important, that the person who told the story was happy with the response. So I think the key point here is that empowering our patients does not mean that we disempower our staff. I have a definition of patient-centred care, I actually call it person-centred care, that person-centred care is about an enriching experience both for the patient and the staff. You can't have patient-centred care without involving the staff members. It has to be two-way traffic. It doesn't work otherwise. I just wanted to show you, and then we'll go to question time. We'll try the two videos, Cathy. It's the 2 weeks seminars. So we might just try one of them, actually. So this is a health service organisation in England, and it's the staff talking about what this means to them and how it's changed their practice. Yeah, we'll play that one, Heart of England.
A lot of us, myself included, were quite sceptical at the beginning, and I think what we're now seeing is starting to catch on. So in your postings, you're now seeing that you're not the only people posting or responding to posts anymore, and you know there's some ward areas who are now taking this on and who want to take over and who want to respond to their own postings, which is quite positive.
I trained as a nurse originally, and from the earliest days of my more senior managerial career, I have been involved in responding to complaints. It's a necessary and appropriate part of what we do, but it always feels a bit too late. The benefit with PO is that we get that almost real time, and they're able to do something about it.
I think for us working in patient services, where we deal with both formal complaints coming into organisation, and we have patient services reps who go out to see patients on the wards, that this is a really good, quick, interactive way for us to work. We're able to see things as they come through and act upon them straight away. The patient opinion gives us the opportunity to identify which service it is and to contact them.
If I'm being honest, I came here almost a year ago now, and I think I expected feedback perhaps to be more negative, and so that balance is also a good thing, and I think accurately reflects the work that we do here. I don't see negative feedback as a low point. I think that's important. It's not. It's the stuff we learn from.
Part of my role is also working with patient experience team, so it's about looking across the trust of all the feedback that we have, and we use the patient opinion as part of that feedback. I think it's nice to be able to go back to people when you've had positive feedback and say to them, look, you know, people have recognised that you've done something good, and for the management to know that.
In the old way, we used to have a query for a complaint response coming from central office or from the complaints managers, and you then need to order the notes, you need to read through a whole lot of paperwork until you can actually respond. So by the time you can respond, often a week or more is gone, which kind of defeats the object really. Whereas what the patient or the relatives post, you can immediately see what the issues are, and you can directly tackle it head on, and I think it's better for us and it's better for the patient.
So just very quickly, then we'll move on to questions time soon, although we'll go to a live demonstration. So this was the site that won the award. It was their site's called Positive About Change. I love that. And you'll see that people can go on and give their feedback in 3 ways. They can go on to and take a short survey that the hospital runs. So that's the plus sign. So they can log into that, or they can go and tell their story. So just grab our widget and put their widget on their website, or they can get in touch and do a compliment or complaint with the the patient advice liaison people. So people can go on, and there's a real sense of you can give your feedback here in whatever way you want to. So just quickly, I think before we go on to demonstrate, it's important that the public have a voice, not necessarily just a survey, and that voice is heard, and not necessarily just measured. And that we should think about starting with what the patient or carer wants to say, not just what we want to ask them. And that if you want to change or improve the care experience, I think it's really about connecting people, the staff and the storytellers, not just collecting data. And do it in an open and transparent way. It's scary. Be brave. Be brave, because it will benefit everyone for the social good. So we're just now going to... there's been a story. Is this mic work? Okay. There's been a. Thanks, Pete. There's been a story about Healthscope today, so we might just go in and have a look at that. Okay, so there's the story. Have a look at that. Kitchen staff very helpful at Geelong Private. Yeah, read it out.
Okay, so we have a story here. Kitchen staff very helpful at Geelong Private Hospital. That heading's done by your mob, isn't it?
Yeah, we just take the heading, yeah.
Okay, so it's posted by Minister as a volunteer advocate yesterday. So not necessarily posted by the patient, but we're not really sure who's posted this. Diabetic patient having had lap banding, initially found it uncomfortable with diet sheets, etc. But now that the hospital kitchen is aware of their needs, things are looking up. As a consumer consultant visiting who regularly visits patients, this patient reported that the kitchen staff were very helpful in regard to their special diet requirements.
So at this stage, Hellscope have about 5 people being email alerted, so they would have been email alerted immediately that was posted. So Cathy got an email alert. And now Cathy's a responder. Usually you only have 1 or 2 people in the organisation respond to keep things consistent. So Cathy's now going to try and respond. Is that going to work? Yeah. So Cathy's going to write a reply. This is live. Remember, it doesn't go live though, on the web. So Cathy's going to say a few things. So thank you for your wonderful feedback about our kitchen. I'm sorry to hear that it took a while for your dietary needs to be met. Hope that you're enjoying the food.
Now I'm going to put something controversial here. So just going to... Sometimes when people respond, they put something that you shouldn't have there, and these guys will mediate it.
Yeah, we just moderate that. One particular organisation assumed it was a he, and it was, and we don't know if it's a he or a she, so we just made it gender neutral. In this case, Cathy's put, our chef has had a bad week, but he'll be... Our chef, Fred, now you wouldn't normally name someone, but our chef, Fred, has had a bad week, and Cathy is submitting that. Here we go. What did it say?
No, it actually said it's not working.
Is it logged out?
No, we've lost a connection. Yeah, we have.
Okay, we're just going to try that very quickly. Just lost the connection. It's back again. The Wi-Fi in the room's not great apparently, so Pete said we should use our phones. So we're just on our phones at the moment. Can you go back? No. I'd log out. You're not logged on.
It's logging out.
Yeah, log in. So log in. So bear with us. This always happens when you do technology on stage.
This is very easy to
Say your password. Sign in. And Cathy, yep, you're a moderator. Yeah, just type in Geelong Private up here. Oh yeah, there it is. We might just do a short response. Even though it'll go live, we'll delete it straight after because people have already responded to this, but we just wanted to show you how it works. Just mention Fred. Yep, hit enter. Thanks, Cathy. Okay, so that'll get moderated. Cathy should get an email alert soon saying her response is now live. So we'll just wait and see.
Here it says 4 staff members have registered.
So if you click on that, you've got one at Geelong Private Hospital, 3, and one at Hellscope. Cathy's obviously Healthscope. So Cathy's just checking her phone. So if you went on the site now, patient opinion, and you had a look at that story, there won't be a response at this point. Yeah, 12 people have currently read it. It only came in, it's quite recent. On average, about 400 people read our stories per story, on average. That'll increase over time. I don't know if it'll get to England, where 2,500 people read every story, or 2,500 reads per story. Yeah, we'll just wait for that email alert to come through. It has to be moderated. So really, any questions while we're waiting for that to come through? Is there a roving mic? Thanks, Pete. Any questions? Whether it be more generic around Standard 2 or the concept of feedback and where you guys are heading with feedback.
I'm going to bring the microphone to you, seeing as though we've got to the end. Any takers? Any questions?
Thanks, Malcolm.
Don't thank him too much. He didn't actually walk up to the microphone. I brought the microphone to him. Thanks, Malcolm.
Malcolm Passmore, Ramsay Healthcare. I suppose just to be a little bit controversial,
please.
The Standard 2 community consultation, in my sense, appears to be written far more around the public system than it does the private system. And we tend to put hours of work into this standard. And a lot of our hospitals have developed, community consultation committees, and where if that community consultant is the customer or the patient, I see it as valuable, but this general community consultation for a non-public private hospital seems a bit over the top.
Yeah, I completely disagree with that. I think that there's no differences between public and private. If we're going to be asking our patients for an opinion in a public hospital, why not ask the patients for an opinion in a private hospital? You just have to be a bit creative about the sort of things you're asking them. So if you're building a new hospital, you probably do need the patient's opinion on whether or not the patient flow works well in the emergency department, or whether or not they like the decor in the obstetric wing. You need a little bit of consumer input into some of those. We know there's been a lot of published stories about how mistakes are made in developing new hospitals because there's no consumer input, particularly things like paediatric wards and obstetric units. The patient feedback, the dichotomy between public and private really is completely arbitrary. There's no reason why you can't benefit from patient feedback in the private sector as much as you would in the public sector. And it's not just done from a token point of view in the public sector either. So I think it's pretty important to have input from your consumers. Something like Bedside Handover, for example, you ask your consumers what they thought of it. The consumer consultants can do that, and then you can change what's happening depending on the feedback you get. It's a very simple quality improvement process, and involving consumers should really help with that.
I think you've had an email alert there, Cathy. I think you've got an email. Yeah, I think you have. Yeah, I think something came through. I heard your phone.
Oh, sorry. By the way, thank you for the controversial questions. We like those. That's great.
So have you got something there? So what does it say?
Okay, so this just says, thank you for the response. We're pleased to tell you we've published your response on the website. You can view your response. So we'll have a look.
Yep. No, you have to go back. Oh, just go to home. Go to home. Go to these ones, view other latest stories. The ones on the front page are just featured stories, so view latest stories. Kitchen staff, it says it's got a response. See how the response light lit up? If there was a change made, it would be green light, a green light. So about 11% of our stories are changing. Have they been moderated? Did they take out? Yeah, they've moderated it. So, and who's it from? Cathy Jones, Hellscope. Yeah. So that's, and you know, the person who wrote that story, who was it? Minister, they'll now have an email alert saying it's been responded to. So they've had 3 email alerts. They've had submitting their story. They've had their stories now live. Now they've had a responses come. So they're being very much heard. And but as I said, in this particular, yeah, so that's great. Yeah. So it worked.
Obviously, we're not going to leave that there. That's not a real response. But normally you would put a bit more time and effort into it than what we've put in today. We've got another question.
Yeah, more questions, thanks.
Vincent Borg from Ebworth. Cathy, I was familiar with most of the tools that you use. One I wasn't familiar with was a doctor bedside question sheet. Can you put a few more words around that, please?
Okay, well that's just the standard situation that occurs when doctor, particularly in a private hospital, when the patient's got a question for doctor at 8 in the morning and you know doctor's not coming in till 6 o'clock that night. This doesn't happen so much in the public sector. So it is a particular private sector problem in some places. And the nurses actually just reply and they say things like, oh, we'll tell the doctor when he gets here, or doctor's not coming, or they kind of, as a patient, you feel like you're being fobbed off. And the nurses are saying exactly what they should say. You know, there's no doctor here right now, we will take notes and so on. But the patient, unless you give a better response, sometimes just thinks that was a dumb question and the question goes away. So you need to grab that question when it happens, and one of the best ways we find is just having a specific, rather than the note paper at the side of the, a notebook or something at the bedside, having a specific piece of paper that says questions for doctor, and it's really very simple. It's just the nurse or the patient writes down the question, and it means the nurse can say, or whoever it is, the family member can say, great, that's a great question. I'm really sorry, but Dr. Smith comes around at 4 p.m. every day. He won't be here till the afternoon. Let me write that down for you so that we don't forget that question. So it's a way of telling the patient it was a good question and also not forgetting the question. And we know what happens when you rely on the medical record for communicating these things. It doesn't always work. So it's just another strategy. It works at some of our hospitals and not so well at others. And then if you've got you can do this in other ways. There's often communication books and other ways that people do this in hospital as well.
Any more questions, ladies and gentlemen? Any final comments?
I guess my only final comment would be thinking about how you integrate the patient experience across your whole organisation, how you get that voice to all members of your staff, not just at senior management level, but filtered right through the organisation. I think the challenge is, as I think I alluded to earlier, how do you give that vibe, that message, that feeling to folk that come to you, that you really welcome that feedback, and it's not just a poster on the wall or a card or whatever, but something that says, this is really important to us, and this helps shapes us both personally and professionally. Your stories or your ratings, whatever form of patient feedback you use, and hopefully it's several forms, not just the one way, whatever that is, that it really sends the message and that it's felt and meant. Because I think to use, I think it was Michael said this before, what are folk going, when they look at your organisation, what will distinguish you as a different organisation? And I think one of those ways is your willingness and your philosophy around the voice of the patient.